And now for our final panel of the day. Some of our panellists will need no or not much introduction, but we're looking forward to a stimulating discussion with the headline of the future research and the future rural health workforce. So if I could invite to the stage Amanda Kenny. Amanda is the Professor of Rural and Regional Nursing at Trobe Health School, and the fun fact on Amanda is that she's a new grandmother, and also she's dying, like many of us, to see if we could dip out and get to the Cartier exhibition, which would be very... anyway, just have a seat. Dave Hallinan, welcome Dave. Dave is the first Assistant Secretary of the Health Workforce Division of the Department of Health, and he's a not very secret ACT Brumbies fan. Can I welcome Chris Bourke, who's the Strategic Programs Director of the Australian Healthcare and Hospitals Association, Australia's first Indigenous dentist. And we're very excited to celebrate with Chris, who got his MBA from Tom Karma on Tuesday. So congratulations, Chris. And finally, but not least, Rob Curry. Rob is a wannabe farmer. In his day job, he's, in his honorary capacity, he's president of the SARA, the Services for Rural and Remote Allied Health, but he is a wannabe farmer, and he rolled his tractor recently with the consequence of severe emotional trauma and consequences.
It's much better when I change for shorts.
Yes. All right. So, thank you, colleagues. What I'd ask is that I'm going to ask each of you what you would suggest are the most important areas of workforce research necessary, and I'm wanting you to think in 2018 and start to think forward about what are the gaps and what are the necessities of what we need to do and we need to be looking at if we're going to have a solid rural workforce policy to the future. So what is it that you, as a practitioner with a particular constituency and either a policy or a particular discipline or a particular perspective, that you think are the most important areas of workforce research, thinking forward from this conference? So Amanda, is it all right to start with you since you're on the end? If you're happy to grab a microphone and have a think about that?
I am. I think that's a great question, and I'll probably talk about my own discipline of nursing for a moment. And I think one of the things about nursing is that we still don't have really good longitudinal workforce data. I had an experience recently where I was talking to a senior politician, and he made the point that in nursing we have 10.1 nurses per 1,000 population in metropolitan, and exactly the same in rural. And so his point was, what's the issue? But of course, you know, bringing it down to just 10.1 nurses per 1,000 population doesn't take into account geographic difference. It doesn't take into account the complexity of client need. And it also doesn't, take into account that I don't think we've done really good workforce planning, working out what sort of nurse we need in these communities. So a lot of the work that's been done, particularly in nursing, is just based on these numbers of nurses we need rather than the types, but also not looking at how we relate the workforce that we need in a community to client need and the types of health professionals that you need in those communities. I think the other thing is, I think we need to start looking at much more innovative models that are not just about traditional workforce models. I think there's some fantastic things that are happening in rural, but often we hear about the dire problems or the misery rather than trying to capture some of the small projects that have been done and working out how we can scale those, how we can develop some of those great small projects rather than taking years and years and years to actually get into practice. The last thing, I mean, I've got a good example at the moment. So we did some work 7 or 8 years ago on paid employment models for students. Actually, so I'm from Victoria, and you know, we're only now doing a pilot of that 7 years later, yet all of that research was done that long ago. So it's about sort of how do we get research quickly into practice? How do we look at impact? And how do we get this knowledge translation happening in a really fast way? And capturing some of the really small stuff that's done and working out how we can scale that to different settings.
So Rob, do you want to think about that with your Sarah hat on, but feel free to stray further away from that if you wish.
Thanks, Jenny May. Look, allied health's quite different, I think, and we need to just briefly summarise that. So we have a really diminishing allied health workforce as you go remote. Everyone knows that. Roughly, I'm a physio, roughly about a third or a quarter of the rate per capita in remote areas compared to city areas. I fully take your point about nursing, and even though you have equivalent numbers in remote areas, you are the backbone of the state health systems. Allied health has no serious funding mechanism to prop up allied health workforce in especially remote areas. We have market failure for private practice or private businesses. The gaps are obvious. We don't have a Medicare system essentially to support that workforce. So we definitely need a whole range of areas of research to make the case for allied health and to explain how it is needed. And that starts with data. We have very limited data for allied health, much better for the registered professions and much poorer for the unregulated professions or the self-regulated professions. We need to, as a fundamental point, start with the data, get good data, and that forms the basis for reasonable research. I've got a million other things to say.
Yeah, well, have a go. Scope of practice?
So really, we need to make arguments to the fund holders, to ministers, to employers about what is the efficacy of allied health in the different professions. What difference do we make clinically and through our programs? More than that, when we're able to do that, because we haven't been all that good at that, there's been work occurring over the past several decades to explain the efficacy. But I think we also need to translate that efficacy into cost benefit, the value for money of investing in allied health services. So if you're a health minister, why would I invest in allied health in rural remote areas, in Tennant Creek, where there's virtually none? Why would I invest in allied health? And we have to make that case. So I was interested in the health economics session before because we don't really understand the lingo, really, and we really need to understand health economics in order to translate our efficacy into a business case to be made for employers. Does that make sense? Sorry about that. I want to put a pitch for cultural safety. We want allied health professionals to be culturally safe in all contexts. The evidence around cultural safe practice is we don't have clear agreement on what cultural safety and security is, and we don't have a lot of evidence around its impact and its benefit. We all, as a matter of common sense, understand that it's critical, but we need to put some evidence, some serious research around why we would have culturally safe services. A pitch for Aboriginal health workers, we're silly, we are not supporting, you can't have cultural safety without Aboriginal people in the workforce. It's not fully achievable. You need more Aboriginal faces in the workforce. We need Aboriginal doctors, allied health professionals, nurses, of course, but if you live in a remote area, your best avenue, the most accessible avenue into the workforce for an Aboriginal person is through the Aboriginal health workforce, Aboriginal health worker profession, either as a standalone profession or as a stepping stone to other things. I just wanted to make that pitch. As a remote physiotherapist in the top end, I could not have done my work as a physiotherapist in remote communities without the health workers. I wouldn't have had a clue. So I just want to make that pitch. Many other things to say, we might come back to those. I better shut up now.
No? Chris, I think that's a perfect segue.
Thank you, Jenny. And of course, better engagement with an Aboriginal and Torres Strait Islander health workforce is, I think, the key to a better remote and rural workforce in this country. I think when you consider that, and I'll talk about nurses a bit, and congratulations to nurses for incorporating cultural safety within your code of practice recently, and well done to you for doing that. But when we consider that there's over 6,000 Aboriginal and Torres Strait Islander people registered as nurses in this country, and a third of them are unemployed, we need to be starting to ask, why is that so? And that kind of research needs to be driven by our research institutions engaging with Aboriginal and Torres Strait Islander researchers in a manner which is not just culturally safe, but free from institutional racism, which is another concept you've probably heard me talking about yesterday. Institutional racism is not the interpersonal behaviour of people who work in a particular health service. Let's be very clear about that. This is not about interpersonal relationships. It's not about the way people behave. It's not about how they treat Aboriginal and Torres Strait Islander people, patients or co-workers. Institutional racism is about the way an organisation or institution is managed, established, funded, governed, its accountability, its policies that produce poorer health outcomes for some racial groups. And an Australian evidence for that we heard this morning in the rate of kidney transplants and end-stage renal disease. And we can see it right across the board in cardiovascular disease. I think of all the, for instance, the AHRW report on waiting lists for non-elective procedures. The only procedure that Aboriginal and Torres Strait Islander people did not have a longer waiting list than non-Aboriginal people for was varicose veins. How can this be? But it's about that level of institutional racism. Now, some work has already been done about that. There's a matrix that's been produced in Queensland that people may be aware of. We at Australian Healthcare and Hospitals Association are working with the Maoris to develop that matrix. It's about incorporating Aboriginal accountability within the governance of an institution, within the professional management of an institution, within the workforce of an institution, and with its accountability. But let's not just think about hospitals and healthcare organisations. Let's turn the mirror on ourselves and look at our own organisations, whether it's an academic institution or an NGO. Do we, as organisations, are we institutionally racist at our organisations? Something for us to start thinking about. But to come back to that particular workforce question about recruitment, which is another piece of work that we're involved in, is that there's quite a bit of work that's been done internationally around diversity management about how to recruit people from particular groups. And the translation of that evidence into the Australian situation could be very beneficial for those organisations who want to recruit more Aboriginal and Torres Strait Islander people into their health workforce. And it's simply about looking at the recruitment process in a different way, using organisational impression management theory combined with what we know that works in diversity management to come up with some fairly concrete operational ideas. I'm a dentist, I like that sort of stuff, about how particular tactics can be used to recruit Aboriginal and Torres Strait Islander people. For instance, sending strong messages of dependency in your recruitment messaging, telling people that you need them to do the job. Not that you're doing them a favour by giving them a job, not that your strategy is there to close the gap in Aboriginal employment, which the Commonwealth has used for many years but is starting to get over, I think. And as a result of that, you create an idea in that person that you, for instance, need me to do the job and that it is me that can only do this job for you. That creation of a level of dependence is particularly important for Aboriginal and Torres Strait Islander health workforce. But I'll stop there and move on to the Commonwealth. Thank you.
Okay, so I run the Health Workforce Division in the Commonwealth Department of Health. And I guess probably the best way to start is to say the Department of Health, we've got a mission statement, and it's words to the effect of trying to achieve better health for all Australians. And that's a good starting point, because I think it does inform and influence how we operate as a department and how governments try to prioritise expenditure. I'll just expand on that mission statement a little bit and add some words that we would think about in the Health Workforce Division, and you'd probably say better health for all Australians, no matter where you live, because my world, we're very interested in access to services and improving health outcomes for people everywhere, and that includes different population groups, rural and remote Australia, all those sorts of things. In fact, the vast bulk of my work is about rural and remote access through one form or another. In terms of research priorities, there could be any number, and it's a difficult thing for me to say what the best one is, because there's you've heard a lot already, and there's a lot out there. But I wrote a list outside, and I'm fairly agnostic as to what the best options are. You could consider models of care that provide better outreach services for communities that don't have appropriate access, or where there's a market failure, where there's not enough money in the system to support permanency. Better use of technologies in remote service delivery. What can we use to provide better services for patients in rural and remote locations that your smartphone might be able to do things that we haven't done before? Using different workforce models. So generalism is the theme of the day at the moment. I think it's been the theme for quite some time, but it's not just medicine, it's outside of medicine, it's nursing, allied health, other health services. And not just in the health setting. So where you've got small towns, communities where we do have market financing failures, where there isn't enough money in any particular stream of government financing to sustain full-time employment, are there models that could draw on the NDIS or aged care as well as health service funding? Are there models like that out there, and what can we do to identify them and promote them? And more than that, we've spent a lot of money and a lot of time on training and workforce retention models. So what are the best ways to train our workforce for rural and remote service delivery, and what are the best ways to retain that workforce? And what sort of research you conduct. I think this was something we discussed earlier. It really does depend on what it is that you're looking at, but fundamentally, if you're after financing streams and changes in government financing arrangements, I think we touched on economics, cost-benefit analysis, cost-effectiveness analysis, cost-utility analysis. So in a past life, in my current life, I passed myself off as a poor quality economist. And I worked in the Department of Finance for 5 years, doing cabinet briefings on a whole range of portfolio matters not related to the health department, but briefings about who was going to get money, how and why, what priorities would the government choose. The lens I applied in that role was one of cost-benefit analysis. So, it was cost-benefit, cost-utility, cost-effectiveness, or cost minimisation, depending on the particular issue. What is it that you're trying to achieve, and what's the best way to achieve it? In health, we tend to fall to cost-utility analysis because it's a good way to compare community benefit with cost across a whole range of different forms of spending. It's a pretty complex beast, the health system. It's 1/10 of the economy, and you're comparing interventions in workforce with interventions in pharmacy with interventions in other activities. So I would stress that in a competition of scarce resources, cost effectiveness analysis is a really useful thing to consider, and that will be a long-term, and I think it has been a long-term feature of health system financing. The pharmaceutical benefits scheme has run that way for a very long time. Health technology assessment processes, the really big financing mechanisms in the health system run that way, and I would encourage people to think about things through that lens to the extent that they can. But there are some things where we're really not going to be able to get that sort of evidence. There are programs to do with retention, rural retention and distribution, where it really is quite difficult to get to that level of analysis or assessment. So something more qualitative in that space would be, I think, highly beneficial. That's it for me.
So if I was a little bit of the devil's advocate, to do a cost effectiveness study and to look at a model of care is a pretty expensive undertaking and requires a lot of joining up, probably between a jurisdiction and the Commonwealth to do it properly. And I guess I reflect on the healthcare home as potentially one way in which the model of care was challenged with a lumped payment for diabetes. So I guess my question to the panel is, where are the funding sources likely to be in terms of doing the sorts of research that we think we need to do? And am I right that what is the balance between small pilot projects like Amanda talked about and a more big bang approach, I guess, to true workforce reform?
I think in terms of allied health, but not just allied health, there are many players out there that are very interested in improving the rural health picture, and I think they can be leveraged with good, smart, clear ideas. And I won't name names, but they're out there and they have resources. Just quickly coming back to, for example, the rural generalist theme, and for allied health, we place a lot of store on that. We think this is a vital way to go. We already have rural generalists out there everywhere. If you live and work in a rural remote community, you have to see, as an allied health person, you have to see who comes through the door. So whether you're credentialed for it or not, you are a rural generalist. We think, though, that the concept should also apply to businesses, to private practice, and just as you said, David, so that I don't think we're going to see a lot of state government lift in funding for rural and remote allied health until we can make stronger arguments of the impact of our services. But I do think that there are great opportunities to have hybrid models of allied health businesses in rural remote areas through registering for My Aged Care, for NDIS, for commissioning PHN work, sessional work with Aboriginal health services, plus treating compensable people and privately insured people who are also in the community. Once we start coming up with those models and researching them, I think that it just creates the clearest new opportunities, in our view, in the short term, if that makes sense. Does that make sense? I don't think this is impossible. I have friends who could have remained as speech therapists in private practice in Katherine had they had there was plenty of work to do, no one to pay them to do it. The need in Katherine is huge. What was missing was funding streams to support that person who was a really good quality speech therapist. Had she been there now, she could have done commissioning work with My Aged Care or NDIS, etc. We fundamentally need to reform Medicare. No one wants to talk about that in the current environment, but CDM needs to be reformed to support much more viable involvement of allied health in rural and remote areas. I won't say any more, but I think this research is not impossible or impossibly expensive. Perhaps
Amanda could comment particularly on the nursing and generalism and the future workforce.
I might make a comment about how we fund research though. I mean, for any of you that have written a NH&MRC grant application or an ARC, they take years, huge amounts of time and huge amounts of work. I work for the Trobe Rural Health School. I'm based in Bendigo. We've had great success with quite a simple strategy, and that is partnering with small rural health services and putting doctoral students into these communities. When you think about having a PhD student based in a community for 3 years, it costs, the health services have been funding them, by the way, and these are tiny ones that, You know, they'd say, oh, we can't afford it, the bigger ones. But, you know, when you think about it, it costs something like about $25,000 or $30,000 to have a PhD student working based in a community, doing a power of work over a 3-year period. And so, you know, that's a strategy we've been using a lot, partnering with industry, looking at what are their big questions around rural workforce, and actually sort of really doing this partnership stuff, because, you know, you get massive value. What is it, about a third or a quarter of what it would cost you for a project worker, but having a doctoral student based out in these communities, getting sort of evidence immediately to the coalface. That's been a strategy we've used really. You know, it's much better for me to get out and talk to rural health services and try and capture what they need than spending hours and hours and weeks trying to actually work on. We heard about 1 to 2% of NH and MRC funding goes to rural, so we're using the strategy much more of how can we put my time, the team that I work with, into actually supporting doctoral students in these communities, and that's working really well. We're graduating 5 next week, so it's terrific.
Do you want to have a comment about nursing and generalism in terms of the way forward? I know this is difficult. I'm
going to make it. I can't get my head around what we mean by rural nursing generalism. I don't understand it. You know, I'm a nurse. I'm a midwife. I've worked in small communities. You know, I've learnt to suture. I can intubate. I can do all of that stuff. And I've had lots of people say we'll be moving to a rural generalist model in nursing. And I must admit, I don't understand what that means.
Fine by me.
I would like to make one quick comment. I think one of the things that we haven't thought about in terms of the rural workforce, I'm going to make a political comment here, and that's about we don't know what the implications of the decisions around MyEFO late last year. For those of you that don't understand that, it essentially means it doesn't apply to medicine, but it applies to nursing and allied health. We now have caps back on undergraduate students. And so when we look at the workforce modelling, the predictions that have been done around nursing, we're saying by about 2030 we'll have a shortage of something like 140,000 nurses in Australia. And that decision last year, for the rural health school where I work, we increased our health students from 700 to 3,500 in a 3-year period, massive growth. And we have about 85% of our graduates working in northern rural Victoria, but we now are capped at 2017 places. We can't grow the nursing workforce at the you know, the way we currently are, because we're not funded for them. No university is going to grow. So it's going to be really interesting to see what that actually does to workforce predictions. So I think we need to sort of look at, I agree, caps in some areas, but I think just this broad brush caps is going to be a problem for us, because we were looking at trying to raise rural nursing numbers by about 20% this year, and we're not doing it now because we're not funded. So,
Chris or David?
Look, I don't know a great deal about the higher education reforms, so there's not a great deal I can say, other than I think the idea of regulating total numbers doesn't mean that governments won't be able to intervene to increase. So I don't think I've ever seen a policy setting that's been set in stone and left in stone forever before. And I think if there was evidence to suggest that we needed to increase the number of nurses in training, or evidence to increase, and that's both registered nurses, enrolled nurses, whatever the case may be, then that would be a judgment that a government would take at some stage. But obviously we'll have to wait and see what happens with the higher ed reforms as they settle in. Oh, yeah, sorry. The question of funding of research, I'm not sure that it's an impossible ask. I think there are certainly models of care out there at the moment that are innovative, that are different, and I think a whole bunch of people in this room would be able to think of locations that they know off the top of their heads where there are people delivering high quality services that are probably having better outcomes for their patients than services that are not using those same models. I'm not sure how many UDRHs there are out there these days, but there's quite a few of those, and we have an academic workforce, we have a university research workforce in rural Australia, and I think there are some opportunities to contemplate research priorities through those organisations, and that's an ongoing source of funding and resourcing for ongoing research. And the current financing models into the system, they're changing, they're different. We're rolling out the NDIS, we're not sure what that's going to mean in terms of rural and remote workforce, but it does provide opportunities to think through things differently. Again, my aged care, and I think we provide some resourcing, certainly through PNIP for nursing models in rural areas. And beyond that, it's a Medicare rebate structure through the CDM arrangements for allied health at the moment. But there'd certainly be opportunity to look at existing models of care and whether or not there are differences in those models that are out there currently.
Just a quick comment about the rural generalist thing again, and I think I do understand some conceptual difficulties for nursing. Yeah, with allied health, we feel that if early career people, allied health professionals, go to jobs in rural remote Australia, if they do have some good quality training about the context and about extra skills they need for that context, we think that would help stabilise the workforce in those settings, and that would have a huge impact for everybody. In those terms, we would like some support. We've obviously been talking with Paul Worley and others, and we would like some support to bed that down and to evaluate that as well as we go along with that what is the impact of skilling up people in their early career for those positions. Otherwise, we have a huge turnover, huge staff turnover in those contexts because people can't hack it really without having those extra skills.
But beyond just the skills, there's also the social connectedness with the community, which doesn't seem to be sort of really well done. You see it happen from time to time where someone adopts a new professional into a community and introduces them, takes them around, looks after them, making sure that they're not heading off to the capital city every weekend in the car or flying out as often as they can afford. But I think that's really something for communities to do. I don't think it's actually a big funding requirement, but those existing social organisations that are already out there in communities, and in many rural communities that's families, need to consider how they engage with a new professional who comes to town to say, well, look, if we want to have this kind of service provided to our children and have the kind of quality of life that's going to keep them here instead of them leaving town, then we need to embrace these young professionals who come to our community and make sure that they are socially engaged.
Anybody got any last comments? Otherwise I might just try and sum up. So I think my conceptualisation was very much that we needed to understand who was the future rural workforce. I think the questions are, do we have enough? And that we've certainly looked, and there are probably some need for some solid longitudinal data as well as snapshot data to make sure that we are heading where we think we want to do. We've talked a little bit about what they do, and obviously that is very much the question of the moment in terms of generalism. And I think we also, and we all dance around it because it's just too hard, is how do we gauge success? And I was particularly struck by that comment about retaining people in communities, because I think we might need to reconceptualise retention. So retention is not what it was for me 25 years ago, coming to a community and you know, staying there and being there. For many of the graduates that I am dealing with, retention is 5 years, and they will have, as we keep saying, 2 or 3 careers. So I do think that if we're thinking about the research and the future health workforce, we also need to keep in mind the level of mobility of that workforce, and the fact that they will probably evolve through a number of different career structures, and that if we are not flexible in the way that we apply the sorts of credentialing and arrangements around our health professionals of the future, that they may decide that they actually don't want to do it. So thank you. I'll take that as a comment. Thank you to the panel, and I think this is a discussion that should continue because, as I said, it is core business for our UDRHs, rural clinical schools, and many of our NGOs, local health districts, to get this right to the best extent that we can, because workforce is such a major component of access in rural communities. So thank you.